Good morning. I'm Steve Finn, Division Head of the General Internal Medicine, and it's my pleasure to introduce this morning's Grand Round speakers, Dr. David Bates, who is visiting from Harvard as the 28th Annual Pecoraro Memorial Lecturer for our division. Dr. Bates is a Professor of Medicine at Harvard and in the Harvard School of Public Health in the Department of Health Policy and Management. I will try and briefly introduce him. He has a remarkable list of credentials. He trained at Stanford, undergrad, medical school at Hopkins, did his residency training in our neighborhood at OHSU, and then went for fellowship at Harvard Brigham, where he's remained on the faculty ever since, and has been the head of the Division of General Internal Medicine at the Brigham for nearly 2 decades. He's served as the Medical Director of Clinical Quality Analysis for Partners Healthcare Systems and Co-Director of the Clinical Effectiveness Program there for many years, and in the interim has served many high-level posts in the Partners organization as Vice President of Clinical Quality and other responsibilities. He has a phenomenal national and international reputation, and it would be take the rest of the hour simply to name all the accolades and positions that he's held. But notable among them are as a member of the board and chair of the Board of Directors for the American Medical Informatics Association, and recipient of the John M. Eisenberg Award, both from the National Quality Forum as well as from the Society of General Internal Medicine. He's an elected member of the National Academy of Medicine and a master of the American College of Physicians. But what David's probably best known for is his incredible research career related to quality, safety, medical informatics. He's published well over 600 peer-reviewed publications, plus another couple hundred commentaries and editorials. He's had, by my count, more than 100 peer-reviewed grants, of which, by my count, also has 18 current funded grants. He's been a prolific mentor and has mentored over 50 junior faculty, fellows, trainees, students, many of whom are now recognizable as national authorities in their own right. And it's been a real honor to have David here as our annual lecturer, and he's going to, as you can see, discuss big data and how it might improve clinical care. So let's welcome Dr. Bates, please.
Thanks so much, Steve. Is the sound good in the back? Yeah, okay. It's great to be back in the Pacific Northwest. I've really enjoyed this visit. And it's been an enormous pleasure to see so many friends and colleagues. I'm going to talk today about using big data to improve clinical care. I think this is one of the most exciting things that's coming down the road, so it'll be fun to talk about it. In terms of disclosures, I have a relationship with EarlySense, with some other companies that I will not talk about today, and we have upcoming research funding from IBM. So I'm going to start by giving you a bit of a backdrop, and then I'm going to talk about a few problems in our healthcare system today. I'll talk about some solutions. I'll share with you what the Brigham and partners are actually doing to try and mobilize our resources in terms of big data. because I think it's instructive to look and see, what somebody's actually doing on the ground, and then I'll give you a short synopsis of the infrastructure that you need to have in place to make this work, and then I'll wrap up. So I'm going to start a ways out. If you look at the quality and safety of care and compare how the U.S. does relative to other countries, we're either at or near the bottom on nearly every one of these metrics. So we have the lowest quality care compared to other major industrialized countries, and the safety of care is not very good. Where we're really at the bottom, though, is in how much we spend. We spend nearly twice what any other major industrialized country spends. And I think that analytics has the potential to really help us out in this area. One book I'm going to recommend to you if you want to read something that's a relatively quick read that introduces this topic is this book, Competing on Analytics, The New Science of Winning by Thomas H. Davenport. How many of you have either read the book Moneyball or seen the movie? So lots of people. And that's about how the Oakland Athletics, with a very modest payroll, achieved really pretty dramatic results. And the key thing that they did was to focus on statistical issues and not kind of how big and strong somebody was or how hard they threw the ball, but really on what their performance was. Happy to note that the Boston Red Sox have bought into this approach, and that's led to our winning the World Series now several times, which hadn't happened for about 100 years before we took this approach. Walmart is an entity that really uses a lot of analytics, and you might not think of it in that way. But they've invested pretty heavily, and I'll just tell you one story from this book. They were trying to figure out what they should do when a hurricane was coming and what kinds of things people would be interested in buying. And they had a lot of hypotheses. They thought maybe people would want flashlights. Perhaps they'd want to buy water. It turned out that the big sellers were strawberry Pop-Tarts and beer. And, that was not on their short list of things. But the next time a hurricane was coming, they loaded up big trucks with those things. And that stood them in very good stead. In healthcare, the sort of the most prominent play in this space has been Watson. How many people are familiar with Watson? Yeah, so Watson is IBM's Jeopardy playing computer, and they are trying to bring lots of artificial intelligence to the point of care. And to improve the way that decisions are made. Their early focus has been on oncology. As you probably read, that has met with somewhat mixed results and has not necessarily turned out really well. But they're doing a number of other things now, and I'm pretty optimistic that they will identify strategies that will be very useful for improving care in the near future. Now, I'm just going to spend a little time on talking about big data. And it's hard to kind of get a mental sense of how big the data that are available today really are. A megabyte is a large model. A gigabyte is the amount of information in the human genome. A terabyte is the annual world literature production. A petabyte is the amount of data in all the U.S. academic research libraries. And an exabyte is 2/3 of the annual production of information in the world. And we're getting to the point where it's not too unusual to have access to petabytes of information. This whole area has been heavily hyped. This is a cover from Nature, but we have all these different sources now. The most notable today is the electronic health record, because now in this country everybody is using electronic health records both inside and outside the hospital. But there are lots of other sources: genetic and genomic data, imaging data, data from mobile devices, wearables, satellite data, And even things like video, audio, social media, and retail data are being brought in some instances. And this has a number of implications. You know, we have all this electronic clinical data from both inside and outside the hospital. In the past, we really did not have very much data from outside the hospital, so that's perhaps the biggest change. Another thing that's happened is natural language processing techniques have come of age. So you can basically look at a string of text and figure out what it means now in essentially real time. And that was something that, you know, was not true until a few years ago. And then we have all these other sources of data to link to, which tell you sort of different things about people and what's likely to happen to them. I want to go through a few big data concepts. So, you know, one important one is that you need a data warehouse. Essentially, every organization will have a big data warehouse where you put lots of things. Typically, the way you want to set it up is that you then set up various data marts, which there might be a cardiology data mart, an oncology data mart, another data mart for pharmacoepidemiology, that sort of thing. But the notion is that everybody will use data from the same database, and there'll be sort of different views on that. Another key concept is data lakes, and these are pools of data that don't necessarily relate to the initial data sets that you have. We're used to thinking about relational data sets where the same things are in multiple data sets, but you might bring in a data set, for example, about the weather. And the weather is very important for predicting lots of things that will happen, but it doesn't have a relationship to most of the other types of data that we use. One of the key things about big data techniques is the data don't have to be as clean as we're used to. I mean, we've spent a lot of time in informatics trying to think about how do we get to clean data. It's better if your data are at least moderately clean, but these techniques are much more tolerant of dirty data than many of the traditional techniques. And tools like artificial intelligence and machine learning help you go through data. And this can be set up as either unsupervised, semi-supervised, or supervised, depending on how much you tell the tools what you're looking for. With unsupervised approaches, you basically are just taking a data set and looking at what the relationships are with a data set, and it's completely hypothesis-free. Deep learning is basically a special case of this, and that's the technology that, for example, is being used to set up cars that can drive themselves. One of the key issues when you do analyses like this is how complex are the algorithms that you're using. The issue with the really complex algorithms is you can't explain to clinicians how you got to the answer that you got to. And, you know, with simple algorithms, you can say, well, you know, there was a relationship between this and this and this, and it's much more intelligible. Another, you know, very key issue, and if you look at studies that have assessed how good machine learning is validation. And, you know, many of the studies just basically fall down on this issue. The problem basically here is that any data set that you look at has a lot of idiosyncrasies. You develop your algorithm on that data set. Your algorithm will reflect the idiosyncrasies of that data set. Unless you test it someplace else, you won't have a good sense of how good it is. And lots of the publications that are coming out now, you know, do not involve really a robust validation, which ideally should be done not, you know, in a totally separate data set from the one that you developed in, and ideally at a separate site. This is going to be very important for research. So at our own hospital, we have an ePath program, we have an Immunology Big Data Genomic program, and groups like this need massive sets of organized data to do the analysis that they want to do. I think this will be one of the most important approaches for solving future scientific problems. Collaboration is enhanced a lot by sharing large data sets. This can help us answer things like dealing with rare diseases, diseases. It can also help with some of the long-standing problems like associating phenotype and omics and imaging. And it's also a really important strategy for public health studies. So at Partners, we've set up this entity called the Partners Big Data Commons. For a long time, we've had something called the RPDR, which stands for Research Patient Data Repository. And that's been really valuable to us. The way that works is you can sit down at your desk and basically ask this tool how many people were seen at Partners with, say, heart failure, who got an ACE inhibitor, who had a potassium level of a certain value. And you can, within 30 seconds, have the answer to that question. If you want identified data, then you have to go to the IRB and get it. But this makes it, vastly easier to do clinical research. You can say, do we have enough people to answer this issue in a reliable way? And with the Big Data Commons, we're taking not just the information in the RPDR, but adding in public health data, biobank data, survey data, a lot of imaging data, a big notes repository, and bringing this all together. And you can then use these techniques to ask questions. This work is led by Dr. Sean Murphy and his team. They've also set up a phenotype discovery center. So the way that this works is there's the RPDR, which I told you about. That's linked to the biobank. There are a few different authorization models. We have a number of scientific repositories, including DNA, images, and blood. And all of that is linked to the IRB. There are a bunch of utilities. And this then can be used to perform research around phenotypes. Here's some data from Limor Daphne and Namita Moda from the New England Journal Catalyst in 2017. And they asked the question, what healthcare sectors most need disruptive innovation? And asked people to rank the top 3 sectors that most need that. Number 1 was hospitals and health systems. Number 2 was healthcare IT. And primary care was third. Interestingly, other things like pharmaceuticals were much lower on the list. And I think we're going to see a lot of change, for example, in hospitals and health systems over the next 5 to 10 years. That we just have to do that, basically given how much we've been spending in healthcare. So now I'm going to take you through a few problems. One is the app marketplace. There are now several 100,000 health apps in the U.S. There have been billions of dollars spent in this space. But if you look at things carefully, you find, what we've found and others have found too is that most of them are not targeted at the people that we need the most help with. They're not targeted at the chronically ill, and they probably are not usable by the sickest patients. We did a review of health apps for the chronically ill that we published in Health Affairs, found that consumers' ratings were poor indications of apps' clinical usability, utility or usability, and most of the apps did not respond appropriately when a user entered even really dangerous health information. So somebody could say that their glucose was 10, and the app would not tell them to do anything. That's not good. Similarly, if they said that they were suicidal, there was basically no response. We need to do better than that. So we looked in a little more detail at why this might be the case. So we asked the question, were clinical experts and patients involved in app development or quality control? And found that in 67% of instances, no clinical expert was involved and no patients were involved. Maybe it's not surprising that there's some issues. In 22%, there was a clinical expert, but no patients. And only 11% of the apps that are in the marketplace were both of these involved. We need to do better. Another question that we asked was, does the app reward the user for engaging with the app or achieving health goals? The answer is yes, and only 22%. This is one of the most basic things in human behavior. You've got to get rewards for doing things, or we tend not to keep using them. We also look to see how well would this work for diverse patients. This is work that we did jointly with Dr. Urmimala Sarkar of UCSF. And And here, what we did was set up 3 groups. There was one group of caregivers, another with patients with depression, and another one with patients with diabetes. People were given condition-specific tasks like enter your blood glucose. And for that particular task, only 43% of people were able to enter their blood glucose. So, you know, that's about as basic as you can get. For more complicated things, people did even less well. And when we talked to the participants, what they said was they weren't confident with the technology, they were frustrated with the design features and navigation, and yet to a person, nearly everybody said that they wanted to use tools like this, and they wanted to self-manage more effectively. They just needed tools that they could understand and that would work for them. Another big issue in the marketplace broadly is the usability of the IT systems that are available. This is work that was done by Dr. Raj Ratwani. It was published in JAMA in 2015. And vendors are required by Meaningful Use to use user-centered design when they build health IT applications, electronic health records in particular. He studied 11 vendors. They fell into 3 categories. A little less than a third had well-developed user-centered design. The next biggest and the biggest chunk had basic user-centered design, so that they basically knew that it was important, but they weren't really using it in actually designing their screens and so forth. And the remaining third had no user-centered design. So that means that 70% of the electronic health records on the market basically, were not designed in a user-centered way at all. All right, so let's move into the solutions area. This is a paper that we published in Health Affairs a couple of years ago. We went through some use cases around which we think would be most helpful for health systems for reducing costs and improving value. And we suggested that there were 6 that were likely to be the most important early on. Those are high-cost patients, dealing with readmissions, dealing with triage decisions, decompensation, predicting adverse events, and then finally optimizing treatment, especially for patients with chronic diseases. So why high-cost patients? Well, high-cost patients are important because about 5% of patients account for roughly 50% of your spending if you look at things in a prospective way. And if you have a population that you're accountable for the cost for, the first step in managing that population is really identifying this group and then figuring out what you will do with them. When you try and do this, you need to include data about mental health, about socioeconomic status, about marital status, living status. Those are things that we have not necessarily collected in a very robust way. And probably the secret sauce in this area is identifying for individual patients, what is their specific need? For some patient, it might be housing. For another one, they might have an issue with food insecurity. And if you do this, my belief, and I'll show you some evidence about this, is that it can make managing these patients much more cost-effective. So, here's the approach that we've used at Partners. We set up something called the Integrated Care Management Plan. We use a tool called the LACE to risk stratify people. This is an okay tool. It's not an especially great tool. We take claims data from the past 12 months. We take clinical conditions from a list of around 30. They're categorized as either high, moderate, or low acuity. And then combinations of the conditions from each of those categories are used to determine the level of clinical complexity. And the things that trigger getting into the cohort include being hospitalized, having ER visits, and some other types of utilization are used. We then assign each of these patients a care coordinator. Our current population for the Brigham includes about 3,000 patients like this. 61% of them are women. The mean age is 71. 32% have a mental health diagnosis, and probably many more than that actually have some sort of behavioral health issue. They take an average of 17 drugs. They cost on average about $2,000 a month, which is 2 to 4 times higher than the average. And the most expensive things in this group are hospital admissions, which account for over 50% of costs. So we built some IT infrastructure to help manage this. And there's an icon that you see. There's a registry, and providers are notified about admissions, ER visits, so that you find out if your patient is having an issue. And then there's an icon that lets you know that your patient's in this cohort, although as a clinician, you know pretty rapidly if your patient is in this group. And we've showed that putting in place this program and more actively managing these patients has pretty substantially reduced their frequency of inpatient admissions. So that you can see that the curve is definitely going down. It's gone down even further since then. What about readmissions? The Center for Medicare and Medicaid Services has strongly incentivized us to reduce their frequency. It's a little tricky with readmissions because only about 20 to 30% are preventable, so most readmissions are not preventable. I think everybody should be using an algorithm to try and reduce their frequency. Some of the key differentiators here, I think, will be tailoring the intervention to the individual patient, making sure that people get the intended intervention, monitoring certain patients after discharge. We have a readmission bundle in which we try to, it was initially 6 things, and we found that we couldn't do all 6 things. So then we reduced it to 4 things, and even then, we were only able to do all 4 a small proportion of the time. An example would be just getting someone an appointment within a week with either their regular doctor or someone else who could deal with their issues. And that's actually, remarkably hard. Often we would end up ticking the box by giving them an appointment, but the patient would know that they were not going to show up at the appointment because they didn't have anybody to take them there, and we didn't have an approach to give them transportation to get there. So that's practically speaking the kind of thing that you have to deal with. Triage is another really important opportunity. And here the issue is estimating the risk of complications at times like when somebody's admitted, when somebody's being evaluated, so they're having chest pain or they're decompensating, or when they're being transferred, say, from one service to another. And here the key is to have a detailed guideline that clarifies how your algorithm will inform care. So, if the person meets these specific conditions, they, for example, would go to a specific level of care like the ICU. A couple of examples here from Kaiser that have been quite successful include evaluating newborns for early onset sepsis and using emergency department composite scores to predict who will decompensate. EarlySense is an Israeli company that we've worked with, and they make this monitor here, which basically sits between the mattress and the bed, so it never touches the patient, and it measures their pulse, their respiratory rate, and it tells you how much they're moving. And they use some big data techniques to actually rapidly process the data. There's a little bit of a phase delay before anybody gets notified. Another thing that they've done is set things up so that any warnings are linked to the patient or to the nurse's handheld device. So if the nurse gets a message on their handheld if their patient does not look so good. We really have in healthcare dramatically underused people's mobiles. You think about it, you're using your mobile device for everything, but how often are you using it really to care for the patients that you care for? The notion is then too that this will facilitate critical thinking by the nurse. So we studied this in a controlled trial in a small hospital in Los Angeles. It included about 8,000 patients, and what we found was the length of stay in the unit fell modestly. It fell about 9%, but that wasn't the big win. The really big win was the chances that somebody would spend time in the ICU subsequently fell 45%. So the goal here is to get to somebody before they actually really crater. And the number of cold blues fell by 86%. We also looked at how many warnings this system generates, and because it uses a little bit of artificial intelligence, the positive predictive value for the warnings that it does give is very good. So there were just 2 alerts for every 100 recording hours, and 50% resulted in nursing action. That's just radically different than the monitoring systems that we usually use, like pulse oximetry, telemetry, and cardiovascular monitors, which have between 160 and 730 alerts for every 100 hours, and a very low proportion result in action. There are many other sort of monitoring technologies like this, and I think we'll be seeing a number of them in routine care, and we should be trying them out and adopting them. We did an economic analysis of this, just modeling ICU length of stay and pressure ulcer rate, and we found that this broke even within a half a year, which is really a remarkably rapid time, and even using conservative assumptions, this paid for itself within 3/4 of a year. So what about adverse events? This is an area that I have been really interested in for much of my career. There's several that seem like particularly good targets, notably renal failure, infection, and adverse drug events. So renal failure is expensive, it's really morbid. Changes in renal function are often apparent before the patient actually crashes. And there's a lot of reason to believe that if somebody's renal function is declining and then you intervene a little bit earlier, they'll do better. Infection is another area that, that we need to do better with. Here, you can use combinations of vital signs and some other related parameters. For example, heart rate variability in very low birth weight infants has been quite predictive. And with adverse drug events, some of the keys are predicting which patients may experience them using genetic and genomic and clinical information. Another huge issue, and the biggest one in terms of outside the hospital, is managing diseases affecting multiple organ systems. Chronic diseases are really costly. If we could predict the trajectory of these things, that could enable caregivers to target complex therapies to patients who would benefit the most, for example, with autoimmune conditions. And registries like PCORnet, being one example, could also be used because they contain lots of longitudinal data. This is a paper that we published in JAMA now 2 years ago. We suggested that one of the keys going forward will be integrating predictive analytics into high-value care and coined the term precision delivery for this. I think that this is really sort of where we want to go. So we want to be thinking about the individual patient, figuring out what the best choices for that individual patient are, and then helping providers select among the therapies that are available. Here's one case example. Kaiser Permanente was focused on curbing antibiotic overuse in neonates, and they used maternal health data to determine the probability of early onset neonatal sepsis before birth. They basically integrated the objective clinical data from the newborn to assess sepsis probability, and they now use that to determine should I or should I not give antibiotics to infants. And they found that about 250,000 newborns can be spared antibiotics at birth using this program. Now, the study that I've done that I've gotten most excited about recently is this one. It's called the PROSPECT study, and it stands for Promoting Respect and Ongoing Safety through Patient Engagement, Communication, and Technology. And our goal here was to transform the ICU and oncology environments through implementation of a patient-centered intervention. We focus both on patients and care partners. Care partners are a really underused resource. And what do I mean by a care partner? Well, it's not the same as a healthcare proxy. We don't all have healthcare proxies, but almost everybody can identify someone who would help you out if you needed to, say, get to the hospital for a procedure or the like. And in this intervention, we basically had two main parts of it. One was implementation of something called the patient satisfactive model. The way that this works is we've found that that both doctors and nurses say that they agree that they should be asking patients what they expect. But when you ask them, do you actually ask patients what you're expecting, like when do you expect to go home? We don't do that on a routine basis. And yet, you know, patients do much better if they know a little bit more about what to expect. So we basically put in place a program to get nurses in particular to ask that question. And in addition, we built a web-based patient-centered toolkit, which includes both patient-facing tools and provider-facing tools. And I'll show you the patient-facing tools in a little bit more detail in a minute. The provider-facing tools basically included a microblog so that the team could have a conversation about the patient and talk about what issues were going on. Here is some more detail about the patient-facing tools. So we built a portal which let patients know who is on their care team. They could send and receive messages. They could get some data about safety. There's a big focus on goals. They could look at their test results, look at their drugs, get some information about food and diet, find out when they were expected to go home, and provide feedback. We also put in place a safety dashboard. And here, you know, all ICU teams have lots of things that they're expected to check on a regular basis. We built a tool that helped them look at that and then just at a glance see, you know, which things have not been done, so you can see which squares are red here and need to be addressed. Here's what things look like if you drill down at the patient level. Here the patient is Hermione Granger. The issue is that her urinary catheter has been in too long and it needs to be changed. And we evaluated the impact of this. We showed that the harm rate fell by about a third. The overall hospital rating improved really dramatically from 72% to 93%. That's the biggest increase we've ever seen for any intervention that we did. The satisfaction also improved for care partners. So did global concordance around the overall goal of hospitalization, although I'll note that we only went up from 27% to 34%, so still a long ways to go there. Disappointingly, resource utilization did not change. All right, so now I'm going to just switch gears a little bit and tell you what we're actually doing at the Brigham. We have had a long history of using analytics for decision making. We put in place something a number of years ago called the Balanced Scorecard, which was intended to help our leadership figure out how we're doing. That included two-dimensional reporting. There was a little bit of interactive analysis capability, but not much. We recognize that where we want to go is to predictive modeling, and we want to leverage both internal and external environmental data to predict the future. We want to do better with staffing levels. That ends up being very important for managing an institution like a hospital. And then we wanted to be able to do complex statistical analyses. And here are some example projects. You know, one is focusing on obstetric inpatient census and other patient volume. Obstetrics was a particular issue for us because one of the groups that had sent us a lot of our obstetric patients basically pulled out. And then we were left with this just massive oversupply of obstetric capacity, and we had to figure out, you know, how to manage that and reconfigure over a relatively short time. That's the sort of thing that's hard for a hospital. I talked about the high-risk program. We're doing a number of things to try and detect patient decompensation. We're focusing on how to manage chronic patients, on provider care variation. It turns out that one of the most powerful tools to identify how you could do better is just to look at variation across providers caring for similar conditions. We're working on our bundled payment performance, and then we're totally redoing the Balanced Scorecard. When you do this sort of thing, you want to put in place a number of front-end tools so people can basically get at the data that you have. And our big data resource is our enterprise data repository. So people can get at that either with their own tools, if they're reasonably expert, or there's also a managed access gateway with a tool called ClickView, which lets somebody who's not real sophisticated go in and access data. And then we also have data in Clarity, which is Epic's database for summarizing information. And business objects can be used to either get at Clarity data or at the enterprise data warehouse. You will want to use something other than just Clarity for the enterprise. That is not enough. And we've argued that every healthcare organization needs to have a data science strategy. You do have a chief analytics officer, Dr. Adam Wilcox. It is, that will be absolutely essential going forward. But you really need a plan around this space for how you're going to organize your data, how you'll let people access it, and ideally, you want to push access out so that it's available to many, many people. The key infrastructure that you need are the data warehouse with data marts, as I mentioned before. You need some analytic tools. You need front-end and presentation tools. You want to set up a variety of registries, which are aggregations of patients with similar problems. And then you also want to basically put in place interfaces to your monitoring devices, because they're producing an enormous amount of data, and it's very valuable to be able to access that. To my chagrin, when we put in Epic, we neglected the budget for any interfaces to monitoring devices, which ended up being an embarrassing omission, which we had to correct with some contingency funds. So, what are the role of data and analytics in clinical care design? Well, I think this will be foundational in every effort to redesign care going forward. And if we can do this well, we'll be able to do lots more than we've done in the past. At the Brigham, we had a pretty good view in the past of care inside the hospital, but we weren't looking at what happened to people outside the hospital really at all. And that's really inadequate for accountable care. Roughly, if you look at a population of patients, 70% of the costs are actually outside the hospital. So you've got to be able to manage that if you want to be successful. And you really need real-time data to make machine learning and real-time analytics practical. Where we want to go is to be giving people information in real time about what options they might take. It's very important to have access to real-time data to do that. Epic does not really facilitate that, so you have to do a few extra things to make that work. And then finally, managing access effectively to all your various databases is critical. This is a place where we could be doing a lot better. We've been very security conscious, and we've really restricted access. And if you do that too much, it substantially inhibits your ability to actually make care better. So to wrap up, clinical data are now nearly ubiquitous in the U.S. The levels of adoption in both hospitals and the outpatient setting are over 95%. And that is just fundamentally different than it was a few years ago. So that's a big change in American medicine. And yet, I would suggest that most organizations have not really figured out how best to use these data. Every organization is going to need to invest. You've got to have a data strategy, and you need to make data available to people. I do think that little data are still very important. There are lots of things that we can figure out without having access to some of the things that I talked about. But big data approaches are going to result in many insights, both in clinical care and research, and as well as management, and that will help us do even better. And healthcare is at the beginning here. If you look at other entities like industry, you are using big data approaches all the time, even if you don't know it. So when you go to Amazon, and they, tell you what things you might want to buy, they're using big data techniques to have figured that out. I've given you a few of the examples that I think are most likely to bear fruit early on. For improving predictions, I think that some of these novel sources are the most likely to provide marginal improvement. And there are issues around privacy and so forth in doing this, but if we bring in information like social data and mobile data, that will help us get much higher levels of ability to predict. So I will stop there and take some questions.
Fun. I had a quick question about, in your practice, how are you addressing issues of EHR interoperability when you're working with big data? I know it's a big issue for us, both clinically and operationally, between hospitals, but also within hospitals, particularly for things like procedure data and things like that.
Yeah, so within the Partners Network, we're all on one instance of Epic. And so the interoperability is essentially perfect. We can see all the information from within Partners. When you go, but if you go to any other healthcare system in the Boston area, we do not have we don't have robust data exchange. We don't really have any data exchange unless you've gone to another institution where they're using Epic. You can exchange some information in a limited way between instances of Epic, but data exchange broadly in this country has not worked very well. And the fundamental approach has been to set up data exchanges, and none of the data exchanges that have been set up have been able to identify good business case. So that really is kind of our big failure with this implementation of healthcare IT so far. The government is very focused on it, and they would like to change things. I don't see any of the current approaches really kind of leading us out of this particular quagmire. There's a couple back there.
Lovely talk, really exciting. What about data safety and confidentiality in, obviously, this expanding area?
Yeah, the question is, what about data safety and confidentiality? And that's a very big issue going forward. We have to set up approaches that are secure. We have to tell people about what the risks are of having their data shared. In the era of big data, the rules are really different, and our current approaches I think are not adequate, and we kind of need to revisit this. People have been unwilling to reopen HIPAA, but it is probably time to do that. And that will be a dialogue that will take a few years. And now there's so much information about everybody. It's become really very complicated.
Thank you for being here. I had a question about, in the era of patients wanting to own their data, how are you guys addressing that on the East Coast? There's this big trend that we're seeing here of, at least my experience, with patients wanting to own their data versus the hospital systems or the payers.
Yeah, well, so legally, patients do own their data, and yet practically we hold the data. What we do provide a copy to patients of their data on request. You have to do that as part of meaningful use, actually. And most organizations have set things up so that it's reasonably straightforward to do that. I think we're going to need to hold their data and to manage it in certain ways. So this is another thing that will probably evolve with time, but we want to be much more proactive in terms of sharing data. We though will not care for someone if they don't allow us to collect their data in our system. It's in today's day and age, it's very hard to do that. Yeah.
Again, thank you for a very interesting talk. It seems like there's some very low-hanging fruit, the idea of bed monitoring, for example. I can imagine very early return on investment. But the larger piece of this seems like there'll be a lot of challenges about funding and where the funding might come from, and whether institutions will share their mechanisms for doing this kind of investigation. And a related question, perhaps, is what about comparison between different countries? Can big data help us inform why your opening slide shows so many differences in both healthcare delivery and the cost of care?
Yeah, well, to address your second question first, the big difference between us and all those other countries is they all have single payer systems, and single payer is just much more economically efficient than the approach that we use. So we're really the only place that is still using fee for service. In terms of sharing data across institutions, there are some interesting approaches already in terms of making that work. So for example, there's something called I2B2, which you may be familiar with, which basically makes it possible to share information amongst academic institutions fairly broadly, and that's been enormously powerful in terms of rare diseases, for example. So there is some work going on. I think broadly these approaches are going to help us become much more efficient, which is something that we just absolutely desperately need to do.
One very simple-minded problem in managing chronic disease, especially in a low-income population, is appointment keep rates in the outpatient department. We struggle with that at Harborview for years. Do you see an improvement in your system that way?
Yeah, so the question is about appointment keep rates. Yeah, there are some approaches that really very dramatically can increase your appointment keep rates. For example, we have completely underused text messaging in healthcare. And if you just send your patients a text message, that's been shown to improve the appointment keep rate. You can use artificial intelligence to predict who is not going to keep their appointment. That's been done very successfully. And with certain patients, you need to just be a little more proactive in terms of making sure that they show up. This is a great example of a clinical problem that is just very readily addressable using this kind of approach.
In the little data world, we think about being parsimonious with ordering tests for fear of generating false positives. And yet the big data approach seems to be to embrace every test known to humanity. And so conceptually, how do you avoid the problem of false positivity in a big data approach?
Yeah, so the question is about false positivity in a big data approach. That's one of the biggest issues. You get lots and lots and lots of false positives, so you have to go through and then use your clinical sense to weed those things out. And I think even in a big data world, we want to be parsimonious, for example, about what tests we do. There's a group in our team that is looking at low value tests, and there's just it's quite clear that when you do low value tests, then there really is this snowball effect that ends up creating a lot of additional testing. I think the best approach is if a test is not needed, just don't do it. And the big data world is just much of it is false positives. The hard thing is just going through and sifting through all these signals and saying which ones are really going to help us advance the ball.
Great. So let's give Dr. Bates one more round of applause.